Thank you. So I'm going to talk something on a white cataract, intumescent white cataract, which we all encounter in our life. So this is a different type of white cataract, intumescent white cataract, which if you see in a two-dimensional view, which we see through the microscope, you will not appreciate this, what I call hill or some sort of bump. And it is visible when you have a three-dimensional dynamic picture, which is seen through the IOCT. So let me take you through this. And from our side, no financial disclosure for this particular video or which I'm going to show in this session with Ashwin. So we know that you have a wide range of white cataracts with the different scenarios, and the absence of white reflex makes things very, very difficult. So this is our classification, which is based on a intraoperative dynamics of white cataract. You can see a wide range of spectrum, right from the totally fluid to a no fluid white cataract, or you have a this type of cataract, which is we call it type 2 type of cataract. If you see here, you have a convexity coming towards the anterior chamber. This signifies raised interlenticular pressure. And you have a sheets of white, you can see yellow-green picture in IOCT, sheets of fibers which are hydrated running across the entire length of a lens. Then in between you have intermingled spaces which are maybe a fluid filled, but they are inside the entire band of hydrated cortex, which are seen as a hyporeflective areas. You can see an entire sheet. If you inject viscoelastic, this will go down, make a little concave, but the pressure will not get released. So this is a type 2 variety of white intumescent white cataract. If you see such cataracts, you have to be a little more careful in doing a capsular access. So let me show you a first case of that type of type 2 variety of intumescent white cataract seen in IOCT. You can see here very clearly, you do have entire sheets of cortical fiber which are hydrated, and you have a spaces in between. Though the convexity of anterior capsule was not that significant, I could think that I would be able to do a capsular access without having to do all those maneuvers to decrease the pressure in this particular case. Let's see how this case goes on. You can see in my left hand side video, I'm trying to make a little small nick. As soon as I make a nick, you can see this hill is starting to come through the small opening, and that signifies the raised interlenticular pressure. And immediately, if you have IOCT, you realize this is going to be a tough case. If you don't have IOCT, you might still feel you can do it regularly because you use high viscosity viscoelastic here. The tendency is to make a smaller capsular access. No fluid is leaking at that time. Only the hill is coming out, and these five, and I thought I'll inject little more viscoelastic. Unfortunately, the air bubble came, and I had to inject much more viscoelastic to take out this bubble out through my side port. You already have Nortens underneath fibers, so I'll try to make a smaller access with this needle. This flap is important. Don't try to go too peripherally. At this stage, I thought I'll pick it with the island peeling faucet, which I regularly use for my capsular access. Everything is going all right at this stage because this is, you can see a tear which is radiating towards 3 o'clock. See little more injection of viscoelastic. You have an entire extension coming to periphery, and see the hill is right. Despite this extension, the pressure has not got released. So this is a patient again. I'll show you again here with a little bit of viscoelastic injection. You're going to distribute the pressure from center to periphery, and that will enhance the chances of rhexis getting extension. You can see entire rhexis got to periphery, and the hill is still maintained, the pressure is still is there. You can see what happens now. I'll go with my IA cannula and aspirate this entire cortical fiber, which is hydrated. You can see now, you can see the concavity coming into the anterior part of the lens nucleus. This concavity will help us to do a subsequent maneuver to complete a keyhole type of access for this patient. So with the ILM peeling faucet, you can see now easily I can make it a little bigger so that this gives access to complete my phaco subsequently without getting difficulty. Let's see another case which gives the way we can manage and decrease the complication. You can see same scenario here. It is always better to stain the capsule with trypan blue dye under viscoelastic cover. And the pupil is moderate here. You can see here, as soon as make a nick here, you'll see that capsule will bulge because of the entire hydrated cortical fiber will try to come out through this small opening. And this will increase the pressure on a tearing edge. Therefore, I'm making a circumferential tearing edge, not let to go too peripherally, be in the central area. You can see this mountain or hill is started coming now. And this is going to make things more difficult. If you see an IOCT here, this mountain is happening because the cortical fibers are there throughout the length of an entire lens, and these fluid pockets are not getting released despite making a nick in the capsule. So these type of white cataracts may not be amenable to aspiration with needle. So these has to be cortical fiber has to be aspirated in these cases to decrease the pressure. So this, you can see I made this with this going quite all right. At this stage, to have a pressure in the periphery, I'll use a dispersive viscoelastic, which will be retained for a longer period without worrying to sudden leak out of viscoelastic, and capsular pressure gradients are maintained. And this you can see here, I can inject the dispersive viscoelastic in the periphery so that maintain the pressure, because once you initiate, there will be some release of viscoelastic and the gradient from center to periphery changes. So I'll inject in the peripheral area like you saw here. Then subsequently with ILM peeling forceps, I'll make a at least 2 millimeter or 1.5 millimeter excess with little care to pull towards the center. Rather than pulling towards the periphery, you have to pull towards the center. This gives the access now. You see that with aspiration with the bimanual cannula, the cortex has been aspirated, and I have a concavity now, and this decreases the pressure towards the capsule now. So this is how it is important to aspirate the cortical fibers, not the fluid, because no fluid in this type of a white cataract introduces white cataract. Now I have aspirated both sides, the cortex, the capsule becomes less tense, the pressure from behind has totally decreased. So once I complete the aspiration of a central paracentral area, then I'll inject viscoelastic. Now you can see my rhexis becomes very, very simple, effective, and you can nicely do a spiraling of this rhexis to a desired size, which will give you access to a nice phacoemulsification of nucleus, which can be soft, which can be hard, depending on what type of white cataract you're dealing with. And adequate size rhexis would be such which gives a good access to phaco, as well as you have a nice coverage of IOL edge, and see how comfortable the rhexis becomes now. In a case of type 2 type of white cataract in IOCT, where the chances of a rhexis extension is very high compared to other types of white cataract, which can be fluid type of white cataracts, where the fluid leaks out and things become easier. You can aspirate with needle, you can do a penchorhexis, you can do any maneuver in a fluid type of white cataract is easier. But once you have a hydrated cortical raised lenticular pressure, the things become very difficult. So that makes challenging, and it is interesting to really see how the entire dynamics of anterior capsule changes with a nick of into the capsule, or a subsequent smaller rhexis you make in these cases. Subsequent emulsification in white cataracts can be easier in a softer cataract like this. This is a grade 3 nucleus. You can do a very nice central nuclear emulsification, take the last piece towards the tip with your second instrument, and you can do a comfortable in the center emulsification of an entire nucleus, and IOL injection can be easier in such cases. So this is to stress how a difficult case would look like when if you don't have access to a visualization intraoperatively, and making things simpler and easier to have a comprehensive outcome for a patient. Once you see, you can do better. So this is what is I wanted to express in this particular meeting. Thank you,
Thank
Aswin, for this opportunity.